Hello and welcome to Taking Care of Cancer from the Clatterbridge Cancer Centre NHS Foundation Trust. I'm Caroline Kenyon and I'm delighted to be hosting episode 2 of this brand new podcast, Taking Care of Cancer. And with us today, we're talking about diagnostics, and with us today are a radiologist, a GP, and a patient whose sliding doors moment meant she almost missed out on a screening opportunity and may well have still been unaware of having cancer. So Kim, interested to hear your story today, but should we start off with some proper introductions? And Kim, do you want to go first?
Yeah, my name is Kim Jones, and I was diagnosed with ductal carcinoma in situ in 2021. And then I had treatments that covered about 6 months. And was given the all clear at the end of it. So I'm really happy to be here today. And if we can encourage people to attend screening to prevent cancer being a life-changing moment, then, then I'm happy to be involved. So thanks.
Thank you, Kim. Yes, Debbie.
Hi, I'm Debbie Harvey. I'm a GP. I work clinically in Bootle. And I also work at the Cancer Alliance, which is based at Clatterbridge, and also work for the Endoscopy Network and for the End of Life Network. So I have quite a keen interest in cancer, and Kim is actually one of our patients. Glad to see Kim here today.
Yeah, well, thank you for encouraging him to come today, Debbie. Dave.
Hi, I'm Dave White. I'm a consultant radiologist. I've worked in the city as a consultant nearly 30 years now, I'm afraid. I work mainly at the Aintree site, but across the Liverpool hospitals, and I'm the clinical lead for the network of imaging across Cheshire and Merseyside.
So you have to tell us what all that means and what it means to be a radiologist.
We will do.
Okay, that'll come out in our conversation. And as you said before we started recording this podcast, you are one of the invisible experts behind treatments for cancer. So it'll be good just to unveil a little bit more about what you do and how you do it. But first of all, Kim, tell us about your sliding doors moment. Where were you that day when you had an appointment for a mammogram?
Well, I turned 50 in the April, and I received an invite for screening appointments, and it was at one of the mobile sites that sort of you see popping up here and there around the city. And I was working from home that morning, and I'd already spoken to my manager, and I was working from home, and I'd already been given the time to go to the screening. And I looked out the window, noticed that it was raining. I'm convinced I'm made of sugar. I can't stand the rain. And there was that moment in my mind where I thought, do I really want to walk there today? It's 5 minutes away. I know I could stay in the house, and I don't have to get changed, I have to get ready. I can just stay here. And it was a fleeting moment. I can say that with my hand on my heart, that it was a fleeting thought. And I just decided, well, if I don't go to the screening, then I'm basically going to have to dial in to a meeting that I was really pleased that I was going to miss because I was going for my screening. And then I just thought, you know what, I'm already sort of got the time. I know exactly where it is. And maybe if I go for another screening, it could be further away because I'm incredibly lazy as well. I didn't want to travel any further than I had to. And I thought, I'm just going to go. I'll just go. I've already booked the time. It's not going to be that much out of me day. And I'd bribed myself with a McDonald's breakfast as a treat afterwards. So I thought, well, I'll go. And if I've got time, I'll nip along to McDonald's and get myself a breakfast for being good, for going for me screening. And that was the deciding moment. It was like, right, okay, I'm going to get ready and go. So yeah, it was a fleeting thought, but it wasn't something, thankfully, that became something that changed my mind. So I'm really glad that I went, really grateful that I went.
And how was the mammogram?
Oh, well, when I turned up at 10 o'clock, my appointment was 12 minutes past 10. And I always remember thinking, wow, this must be like a military operation. 12 minutes past 10 is really precise. So I thought I'd better get there early. So I turned up at 10 o'clock and I opened the door and there were nurses sitting in the reception part of the mobile where they were doing the screening, and they all jumped. It was I just opened the door, and they were really surprised, and I was really surprised that they were really surprised. And I looked around, and there was nobody. There was nobody in the mobile. So I was like, "Oh, am I in the right place?" And she went, "Oh yeah. You're here for your appointments." And I had my little letter, and they went, "Right, that's great. Well, you're early. We might as well see you now." And the woman the nurse who did the screening was amazing. You could just tell how experienced she was. I literally didn't have to move. I was like a human mannequin, and she, move your hips there, lift up your arm, hold on to that, move forward, move back. And it was just done and dusted so quickly that by the time it was all finished, it was like 8 minutes past 10. So I was like, oh, excellent. I've actually got my appointment finished before it was due to even start. But I think the biggest surprise to me was that there was nobody there. It was just empty, and these nurses were sitting there waiting for someone to turn up. Thankfully, I turned up because ultimately, obviously it was discovered that there were, cancerous cells, and that I was caught early enough as part of the screening programme to be able to be treated in such a way that it didn't really feel like it was a life-changing moment, but it would have been if I hadn't have gone. That would have been a complete... the path I would have taken would have been completely different. And, I felt absolutely fine. I had no symptoms. I didn't feel tired. I wasn't in any pain. It was just, I felt fine. I just thought, I'm going to go. Nothing's going to come of it. It'll be fine. And it wasn't. But thankfully, I went to the screening. So in the end, it was.
And presumably the reason that mobile unit was empty was that there were other people who hadn't turned up for their appointments.
Yeah. I was so surprised. I really thought it would be chock-a-block full of people. I thought, I'm not going to get seen as soon as I walk in. And it was like I got VIP treatments because I was the only one there. So, it was, they would help me around and go in here and we'll do this. And they were really informative, but the nurses were brilliant. The nurse, whoever she is, who did my screening, was so massively experienced. You could really tell. Just the way that she moved me around, the speed it was all done with. And it was 8 minutes of my life that actually changed, thankfully in a positive way, the course of my life. Because if I hadn't have gone, if I hadn't been invited, if I hadn't have turned up, all of these ifs, it would have been a completely different outcome. God knows how long I would have waited before I actually found out that there was something there to be worried about.
Quite often with screening, so we have 3 screening programs. We have breast screening, bowel screening and cervical screening. When people feel well and they don't have symptoms, they don't appreciate that it's important to get checked. So we do have issues with people not attending for screening. There are lots of other reasons why people don't attend. So sometimes it's because of the weather, possibly. Sometimes because people are busy. People have a fear, so there's still a lot of fatalism around having a cancer diagnosis. People still die of cancer, but actually we've moved on so much even since I qualified as a doctor 30 years ago. So really, really important that people attend for their screening. Certainly things like cervical screening, people sometimes find it hard to get an appointment to get their screening done. We're trying to improve that with opportunities for people. People sometimes think that screening might be painful, so sometimes certainly mammography can be uncomfortable, having a cervical screen can be uncomfortable, but the professionals involved with that will always try their very best to make it as comfortable an experience as possible.
Yeah, it was the most uncomfortable part of the treatments that I received, but...
What, throughout your cancer treatment?
The whole thing, yeah. It was that initial, because, your boob gets squashed. There's no good way of saying it. But it wasn't that bad. I've stood my toe and been in more pain than when I had my breast screening. So if that was the worst of it, then it was nothing really at all. Yeah, it's uncomfortable. It's not great, but it's nothing.
It doesn't last for very long, does it? It's literally a few minutes.
I don't even remember it. I remember stubbing my toe on the side of the table, and when you have that memory of that pain, and I don't have any memory of pain when it comes to the treatment that I've received.
So after you had the mammogram, what happened then?
After the mammogram, obviously it was there'd been a discovery of something, cells or parts of the breast that, you know, warranted further investigation. So I had to go for a biopsy. I'm quite embarrassed about this because I got myself quite upset. I had a biopsy many years ago and it was painful. It was shockingly painful. And I remember lying on my side and all of these lovely nurses were all, you know, trying to make me feel better and don't get so upset, and they were holding my hands and they were so lovely. I'm really embarrassed now. But there was a couple of clicks and then another couple of clicks and then it was done. And I was like, okay, when does it start? And they went, no, we've done. So I was like, what do you mean it's done? There was nothing. I think there was an anaesthetic that might have stung a little bit, but again, I don't remember. But the biopsy, that was the bit that probably surprised me the most. I thought that would really hurt. And it was done in an instant, and it was like, and that was it. It was over. So I was so pleased, and I was so relieved at the end of it because I thought it was really going to hurt, and it didn't at all. That actually is probably the most amazing part of it for me, because I do remember the initial biopsy that I had many years ago. It was only for a cyst. This was just nothing. It was just nothing. There was nothing to remember.
Did you have any other tests apart from the biopsy?
No. The biopsy was the cells that they'd sort of singled out to be tested had cancerous cells. You know, it wasn't a tumour, but obviously the cells were getting together to think of a way of ruining my life. But it just didn't get that far. It was just the cells, yeah, there's something wrong, we need to take them out. And then the next sort of treatment after that was the operation on my breast. And there was obviously a couple of appointments in between for different things. But the actual sort of testing was just the biopsy.
So your treatment consisted of surgery?
Yeah. There was 2 surgeries. The first one was to take out the cancerous cells, and the consultant told me that there had to be a clear margin of healthy tissue, and the pathologist had sort of indicated that they hadn't taken enough. So then I had to go in the week before Christmas, just to take just a little bit that, you know, that they'd missed out. So it was two operations, but I had more discomfort and more hassle with a broken wrist and the operation I had on my wrist than I did with the operations on my breast.
Did you have any further treatment?
There was the blast of radiation. Is that what I was saying? Radiation. And that was a few weeks after I was kind of healed from the operation. And that consisted like 15 minutes over 5 days in Clatterbridge and Aintree. And yeah, it was all done and dusted.
And how are you now?
Oh, yeah, great. I had my last screening in October just gone, just like the follow-up, because I've got them once a year for 5 years now. And it came back as all clear. So you can't have a better outcome than nothing at all being there. So yeah, I'm really grateful that I went.
It's great that's such a positive story, and after that moment in which you almost didn't go. It's a really good story to hear. But for other people listening, of course, it could have been different. So it'd be good to hear what might have happened, if you like. So, Debbie, if somebody might come to you with symptoms, so mammogram will pick up something at an early stage, which is why it's so good for people to go for their screening. Yeah. But people will also go to their GP, first of all, presumably, if they think they've got a symptom. What might prompt them to go and see you, typically?
So if we're looking at cancer in general, people can present with a whole host of different symptoms. I guess what I would say is that there are some cancers where you look at somebody or examine somebody and it's clear that probably is what the issue is. So, for example, an older lady with a breast lump, there'll be certain features that we look for, but, certainly women 50 and plus with a breast lump, we would be referring them for further investigation in a hospital setting. And there will be, certain skin lesions that look like a cancer, and we'll refer those straight through. With a lot of other cancers, people have lots of different symptoms that could be anything. And so, and a lot of patients don't come in necessarily thinking that they've got cancer. They'll think there's something wrong and I'm not sure what it is. So they may come in with a long list of different symptoms. So they may have lost a bit of weight. They might be feeling tired. And that's quite vague. So that could be anything. So as a GP, what I'd need to do is to take a clear history from that person, examine that person, and then the differentials, the other diagnoses that we could be thinking of will narrow down. We may then need to think about doing some blood tests or some simple investigations, and that may then hone us into thinking, actually, this person may have, I don't know, pancreatic cancer, so we need to organise a scan for them. So when we have assessed somebody, hopefully over a short period of time, so we need to do it as quickly as possible, we need to gather all those results, and then there'll be certain criteria that we have to use to then refer that person to secondary care hospital, and we'll do that on an urgent suspected cancer referral. So the guidelines for that have changed a little bit insofar as by day 28, so from 28 days from that initial referral, 75% of patients will hopefully know whether or not they have cancer or not. There are really clear pathways and diagnostics that hopefully as GPs we can now access that make that as quick and as simple as possible, because the earlier that we can detect cancer, the better the outcome for our patients.
When should a patient go and see their GP with symptoms? It's quite hard, isn't it, to know when. What would you say to a patient listening who might think, don't know if I've got one of those symptoms Debbie's just mentioned?
Yeah, so there are lots of different symptoms that people can present with. I think as a general rule, what I would say to patients is, if you notice something that's changed for you, that you really can't explain, and that persists for perhaps a cut-off of 3 weeks, then you need to come in. But clearly, if somebody's feeling very unwell with those symptoms, they need to come and see us sooner. But as a general rule, that's what I would say, because there are so many different symptoms of cancer: weight loss, lumps and bumps, persistent cough. So if people have a cough that they can't explain and it persists for 3 weeks or more, even if they're a non-smoker, we would want to see them. And the reason for that is we know that 20% of people with lung cancer do not smoke. So cough is quite an important one. Obviously, things like change in bowel habit, bleeding either from the bladder, so if you notice blood in your wee, or if you notice blood in your poo. There are a whole host of different things, but really the key thing is a change. So we have people with COPD, chronic obstructive airways disease, who will have coughs a lot of the time. And what we'd say to them is, if your cough has changed, you need to come and see us. So that's the key thing, I think, for me, is a new symptom or something that has changed for you, which you can't explain, which is worrying you, and it's not going away.
Yeah, great. Thank you. And then when that referral is made to secondary care, there's a whole array of tests available. Dave, could you tell us a bit about that, and also how typical is Kim's journey, and what tests might she have had if it was much further on with that cancer?
Yeah, Kim's journey is you had one imaging investigation done, and it was a radiographer that did your mammogram. And that would have gone to a radiologist who would have looked at that film and said, there are signs on it that this is worrying. And then you would have seen a second radiologist, and that would be in the breast clinic where they put the biopsy and needle it. If we saw that initially and we thought that was, it was a cancer that had gone to another stage, so a more malignant tumour, we could have done other investigations at that point. So obviously, we'd want to check whether it's spread elsewhere. And the biggest tool that we have for that is something called a CAT scan. So that is you lie on a table, we inject you with some dye, and then you go through on a moving table through an X-ray tube, and typically that is our standard form of staging tumours, whether it's bowel, whether it's chest. And we're doing lots of screening now with low-dose CT, especially in Liverpool. So we're picking up our smokers over a certain age, and they're going in something called the Healthy Lung Project, and we're picking up very early cancers in that space as well. And we've got CT scanners now all over the show, so we've popped them in the community as well. You were seen in a mobile unit, and we do have CT scanners on the back of vans, but they tend to be on static sites. So we've got one at Paddington, we've got one at the Women's. We've obviously got lots of scanners in the big main hospitals as well, but around Merseyside we have these community diagnostic centres, so they have CT scanners, and that allows GPs to get more access to CT scans as well. But again, this is a test that doesn't hurt. You know, you have a little injection, you feel a bit of a hot flush with the dye, and then as a radiologist, that's my job then to interpret those studies when they come through, and that's what we're trained to do. So we have specialists in bowel, we have specialists in lung, and we will look at those scans. And there are other scans that we can do as well. So the easiest one is obviously ultrasound. So Debbie will ask for a lot of ultrasounds because it doesn't use radiation. There's always a risk with radiation, but it's a very minimal risk and you shouldn't worry about it. The other one that lots of people have is something called an MRI scan. Now that uses a big magnet basically, and you have to lie inside it. So a lot of people get quite claustrophobic in there. But what we do with people who are claustrophobic is we can sedate them ever so slightly to go in there, but we can also talk them through it. And like you said, a lot of it is about the fear of having something done. And once you've seen a scanner or you've had one, then you think, why was I worried about it? But people are having them more and more, so people are used to having them as well. And then we've got a whole range of investigations called nuclear medicine scans, where we can actually target cells and we can give a dye that's radioactive. It's a very low dose, but that gets picked up by cancerous cells. So you might get referred for something called a PET scan, and that type of scanner looks at lymph nodes elsewhere in the body where you've got cancerous cells and allows the clinicians to decide what treatment options you can have. So a whole range of scans.
So for some patients like Kim, it was a fairly swift diagnosis, but are there others where you think there's cancer, but you have to do lots of tests because you can't quite diagnose it? Does that happen?
Yeah, we take pictures basically, and sometimes we're not sure of what they are. So there are, the human body has so many variants in it, and it's very difficult to be 100% that that's a cancer that isn't. So there are patients that we will monitor, and we will monitor them 3 monthly, 6 monthly to understand, is it changing? But there are other ones as well where you think, I'm not sure about this, but I think if I do these other tests, it probably is malignant. And the clock is ticking on those patients. So we need to do it quickly, and we will do. We'll do all those scans within 2 weeks, and we'll report them in 2 weeks as well. So, the onus is on us as radiologists to sort that out for the clinician and let them know what's going on. And it might entail a biopsy. So, we biopsy in the body as well as radiologists, as well as things on the superficial skin surface. So we can put biopsy needles anywhere really in the body, and then we get the diagnosis from histology from that point of view.
Now, Dave, if you don't mind me saying, so you've been doing the job a while, haven't you? How have things changed for you as a radiologist over the time?
So when I first started in Liverpool, we had 2 CT scanners, and they were very slow. We've now got tens of CT scanners. So we also used to take every image on a film, like you did with an analog camera. Now everything's digitized, and I can look. So say, for example, you go into Arrow Park, you go into mid Cheshire and you have a scan done, and you want a second opinion as a radiologist, I can look at it instantaneously on the X-ray in my room, in my office. And we've also, as radiologists, we have them all at home as well. So so I can, if I get phoned up about opinion, I can look at the scans in the whole of Cheshire and Merseyside, which is a real bonus for our patients, so we can get that diagnosis as quickly as possible. But MR wasn't even invented when I was a young radiologist, and there was no such thing as PET-CT either. So those things have all come on board since, radiology is expanding massively, and we don't have enough, unfortunately, radiologists in the UK.
What about artificial intelligence? I have to mention that because I can see your expression, raised eyebrows in case you're not watching. But they say that's going to not take over your job, but certainly lighten the load, would you say?
No, I think so. In America, there's been a lot of debate about you shouldn't ever train a radiologist. And I always, my pushback to radiologists that say that is, my son is actually trained to be a radiologist in London. He's just got on the rotation there. And I wouldn't allow my child to do a speciality I didn't think would be there in 10 years' time. The radiologists that work with AI will take over from radiologists that don't work with AI. And artificial intelligence at the moment is really in its infancy. Everyone talks about it. We have it. So we're one of the networks at Cheshire and Merseyside. We have artificial intelligence already looking at scans, helping us as radiologists. And there's more and more of this software coming on board. But because there's so much work to do, it will take some of the mundane work away from us and allow us to do things that will increase the patient pathway. The other thing it will do as well, it will help us diagnose things much quicker. So that is coming. We've got it already in Cheshire and Merseyside. We are actually evaluating it as well nationally as well, which is really important as well. And I don't want people to when they're listening to this, to think a machine is actually going to look at my scans and how will I know that, that's 100%. That is not happening. What the AI is doing is actually highlighting where we should look as radiologists and then decide what the outcome should be. So that's where we're going. We've got it already. It's coming. More of it's coming. And it will come in other specialities as well. So pathology, it's going to come very quickly. And dermatology as well. So those two specialities and ours are the three forefronts for AI. It's very exciting.
The raised eyebrows weren't because you don't want it to come. Is that there's a lot of perhaps false assumptions about what's going to happen as a result?
Yes, I think there is a lot. People believe that the machines will take over and it'll be much easier. There are bits in radiology where it will take over. And there's you read a lot in the press, don't you, about it will take over breast imaging, for example. I think it probably will take over a lot of breast imaging, but they're overwhelmed and we can't get breast radiologists. So there are positive bits for this. But we have to evaluate it. We have to know that it's clinically safe, and we've got lots of processes in place to do that. So reassure people it's not a machine. They don't go to a CT scanner now, go through it, and a machine will read it. That a machine will read parts of it, but not all of it, and a clinician will make the diagnosis at the end of the day.
That's really interesting.
It is, isn't it? Fascinating. And a lot to look forward to. We're now going to hear from Deputy Medical Director at Clatterbridge, Dr Rosie Lord, about genetics and the role of genetics in diagnostics. So over to Rosie Lord at Clatterbridge.
So only about 5% of cancers are caused by an inherited genetic alteration. So the vast majority aren't caused by these gene alterations. They may be caused by what we call a genomic alteration. That's the study of all our genes and how they interact with each other in the environment. But actually inherited gene alterations are only responsible for a small proportion of cancers, but it's really important because there are ways we can identify these people in advance and hopefully prevent people from developing cancers in the future. So certain types of cancers, some breast, some ovarian cancers, prostate, pancreatic cancers, a whole range of cancers can be caused by inherited gene alterations. And so knowing who these people are gives us really, really important information, not only about diagnosis and prevention, but also about how the cancer may behave or respond to treatment. It is a bit of a complex area. If you have a very strong family history of cancer, then it would certainly be worth talking to your GP about that risk. Or if you have been diagnosed with a cancer, you may undergo genetic testing as part of that diagnostic or treatment workup. If you were then identified with one of these genetic alterations, recommendations may be made for your family to be tested, and so that can spread out to wider family members, so preventative measures can be taken. In terms of The wider testing, when we know people have cancer, the genomics testing, these are tests that are done on the actual cancer cells themselves. These may not be inherited alterations, but they can certainly have a very important impact on the type of treatment you receive for your cancer, and again how you may respond to treatments, or potentially some of the, how you may be affected by some of the cancer treatments in terms of side effects as well. This is an area that is really exploding now in terms of how much we're using it, and it will certainly get much more widespread with the newer technologies that are coming about. It's being used a lot more at diagnosis time, and also, as I say, the genomic testing is used almost standardly in many cancer types to understand the best way to treat the cancer. It's a way of making it a more personalised treatment, and as I say, the best way to give the most effective treatments, reduce side effects, and also hopefully for giving that wider family information that can allow people to go on to have preventative procedures or treatments to reduce the risk of cancer in the future. So I think the drive is to make this much more widespread, and I think we'll see it a lot more in our clinical practice.
Thank you, Rosie. Dave, you have got your own cancer journey. Are you willing to share it with us and what happened to you?
Yes, I am, because I think men don't go and see their GP when they should. Mine's probably a little bit different because of who I am. But two of my friends were diagnosed with prostate cancer, and I, like all men, as they get towards 60, start going to the toilet a bit more. And I thought, should I get my PSA done, which is a test for. There are problems with it, but it's a test for prostate cancer. And I did do. And when I got the result back, I couldn't believe that it was quite raised. And anyway, so I went to see one of the local urologists, and I was very quickly then sent for a biopsy, where they take multiple biopsies of your prostate. And then I found out that I had quite a high-grade tumour. And but fortunately, and some of this is because I had gone because of my friends, it was caught early enough to have surgery, and I had a radical prostatectomy about 4 weeks later. And that's about nearly 2 years ago now. And I haven't had to have any other treatment since then. But I've got lots of friends who are on anti-androgen, which is a hormone treatment for their prostate cancer. But yeah, men tend not to knock on GPs' doors, do they, as much, and ignore
the wives have
made them do it. And for me, it was just, I was just getting my lipids checked, and I just got my PSA done, and then picked up my tumour. And since then, there's a genetic link, and my brother's had his done as well. So he had a tumour as well, so he's had to have it done. And my boys are now, when they hit 40, will be on screening as well for it because of the genetic link. But there are so many people I know now with prostate cancer.
Has it affected the way you are as a clinician, your practice?
I'm definitely more empathetic. I don't. We're all taught, aren't we, as doctors, and I think we do understand and we do see what people go through, but until it happens to you, you never really understand it. And I think the NHS is good. I think I did get treated quickly, and I did. I'm a bit different, aren't I? Because I'm a senior clinician in that system. But people were very kind during it, and explained everything to me as well. So. And I hope I do that back to other people when they knock on my door. And I understand why people are scared, especially when you come into one of our X-ray departments. It's full of computers everywhere and big machines, and that's one message to take from this as well. If you're unsure, give the department a phone, speak to one of those nice radiographers, and we bring people in just to show them the MR scanners, just to put their mind at ease, to say this is not going to hurt you, but we're going to get you through this as painlessly as we can through the other end.
That's wonderful. Thank you for telling us your own story. Just going back to you, Kim, you mentioned time, how long it takes from that very first diagnosis. What happens next? How long do you wait before the next step? Kim, can you recall what happened to you? You went to the mammogram. Do you recall what happened next in terms of how many weeks or days?
So I'd gone for the screening in late August, and then I had a letter to say that I needed to go and have biopsy taken. I can only say that from that minute on, I didn't lift a finger to do anything at all. There was appointments made. I turned up. I went to saw whoever it was that I needed to see. Biopsy. Then I got the results from an amazing consultant in the Royal who. There was a point where I was thinking, this is bad news, but it really isn't, because of the way he was explaining it to me. He was brilliant. And then from that point on, it was just appointments, and not tons of them, but it was really rapid. It was an appointment for this, okay, going to do that. An appointment for that, appointment for the consultant, go there, do this, pre-op, post-op. It was just one thing after another. And I think if we look at it probably from the beginning of November was when I was diagnosed. By January, I'd had all of the appointments and two sort of very minor operations. When I say operations, I always imagine something so much more serious, which is ironic considering what we're talking about. But everything was so quick and everything was so at pace that I kind of, not that I didn't have time to appreciate it, but I think it was so regimented. My journey from start to finish was so quick, so smooth, and I know that's not everybody's experience, but it was definitely mine. That I kind of blinked and it was over, which was quite surprising, and then I kind of just went off and lived the rest of my life, kind of thing, which is great. But it was. I didn't have to do anything. I just turned up, just be present. It was the only thing that was asked of me, and everyone that I spoke to, from from the receptionists to the consultants to the Macmillan nurses to the GPs, it was just amazing how I was treated, and I didn't feel like I was being looked after. I felt like I was being cared for, which is a very different perspective to have. And when it was something as scary as this, which it was at the beginning, but my expectations were managed, I couldn't have been given any more information than what I had. There was no point where I felt like I didn't know what was happening or what was going to, I didn't know if it was going to hurt or not until you do it. And then I kind of felt like a bit of a fool at the end of it. But it was just one thing after another, blinking, it was over. That's how it felt looking back. It didn't feel like it was a long time, and it wasn't a long time. November, diagnosed, and the February was when I had me last bit of radiology, but I had to wait for a few weeks for the wound to heal before that I went there. But everything was just so quick. That's how it felt to me.
Yeah, just from an imaging point of view, we try to get that initial staging scan, if it's CT, within 2 weeks and reported. So that's our standard that we're going for. Now, it might seem a really long time when you're not knowing whether you've got cancer or not. If it's other tests, some tests we might only do a couple of times a week. So there might be a delay for it. And then, as Debbie said, that MDT process, which we're all part of as radiologists, again, might ask for other tests as well. But the initial sort of CT staging scan that a lot of people have should be fairly within the next week, when you've initially gone to the GP or gone to the specialist to say, I think I've got something wrong with me. We could get that done fairly quickly and then report it. But again, it's down to pressure on the system as well, of what's going on at that point in time as well sometimes, but fairly quick.
Okay, thank you. Well, I hope for everyone listening and watching, it's been given us a good understanding really of what happens after that very initial diagnosis, all the tests that are available, and how the advances that are coming along in diagnostics, which won't replace our radiologists, but will help them. Thank you, Dave. Finally, then, can we end up with some kind of message to people listening and watching about, coming from your own perspectives, what would you say about somebody who's going through that process of being diagnosed with cancer?
So I guess from a GP point of view, I would have 2 key messages even before they're diagnosed. So I think the first one is, if you're invited to be screened, whether that's for bowel cancer, cervical cancer, or for breast cancer, and as Dave mentioned earlier, we have targeted lung health checks on the horizon as well for lung cancer. It's a free test. Please go. The earlier we diagnose cancers, the far better the outcome. And my other, sort of, I have 2 messages. My second message would be, if you're aware of something that's changed for you and you don't know what it is, please contact your surgery so that they can sift through your symptoms and signs. The likelihood is it probably isn't cancer, but we need to make sure that it isn't, and then get you diagnosed if we think it is.
Thank you, Debbie. Kim?
Oh, I think part of me is a little bit embarrassed that I get invited to something like this, that my story is something that people need to hear, because my story should be a non-story. People should just be getting the screening and then being treated and then going about their lives. And the fact that so many people don't turn up for something that took 8 minutes of my life, that actually ended up saving it. Because if I'd have left it, if I hadn't have gone, I don't know how aggressive it would have been. I don't know what the outcome could have been. I might have missed the next screening. I might not have gone.
So to summarise, what would your message be?
Turn up for your screening. You're getting it for nothing. Next to no time of your day, go to your screening.
You heard it from Kim.
Yeah, here's it for your face.
And Dave?
There's a theme here, isn't there? Turn up for your scan if you've got one booked. And if you can't make it, phone us and let us know, and we'll rebook it and book someone else in. Some of them are very expensive scans. And the second one probably is, if you're worried, phone and we'll sort you out, whether it's a leaflet, whether it's a video, or actually showing you what you might go through. From a point of view of the scanners, if you're really worried about something that you might not turn up for, then give us a phone and we can sort you out, hopefully.
Just ask for Dave.
No.
Yeah.
I won't always be there.
Everyone was so amazing. All the Macmillan nurses, the doctors, everybody was so amazing, so lovely, so nice, that you kind of feel a little bit bad about being scared, because they obviously do this every single day and they're experts at it. These are specialists. These took years of their life to learn how to do this, and that I had access to that when I needed it the most is actually makes me quite emotional thinking about it. Sorry.
Thank you, Kim.
Sorry.
Well, thank you. Thanks, everybody. Thank you, Dr. Dave White, Dr. Debbie Harvey, and Kim Jones. Thank you very much.
You.
Thank you.